Hello. One of the most overlooked conversations in transfeminine care is what happens to testosterone after surgery. Not too much testosterone, too little. Cisgender women produce testosterone also. Most come from the ovaries and adrenal derived hormones, and it may contribute to sexual desire, arousal, energy, mood, muscle maintenance, and sexual satisfaction. After an orchiectomy or vaginoplasty, that includes removal of the testes, the body loses its primary source of testosterone. The adrenal glands still produce androgen precursors, but some trans women and trans feminine people end up with testosterone levels much lower than those typically found in cisgender women. For some people, that feels perfectly fine. In fact, they enjoy having very little testosterone and don't need anything changed. But others notice a distressing loss of sexual desire, reduced arousal or pleasure, difficulty reaching orgasm, or a general sense that something has felt different since surgery. Fatigue, low mood, maybe medication effects, thyroid disease, anemia, sleep problems, relationship factors, and changes in genital sensation can cause similar symptoms, so testosterone should never be assumed to be the only explanation. This is where carefully monitored, very low dose testosterone may be an option. I generally use a small amount of transdermal gel or compounded cream and adjust it according to symptoms, side effects, and of course, most importantly, laboratory results. The goal is not to recreate a male testosterone level. It's to find the lowest level that provides meaningful benefit without unwanted masculinizing effects. Many guidelines for testosterone therapy in women recommend remaining within the laboratory's physiologic premenopausal female range. In my practice, some patients feel best around 50 nanograms per deciliter, while carefully selected people may prefer an individualized trial, even approaching 100. But that upper range is not right for everybody and may be above some laboratories' quote normal female reference range, and it requires a clear discussion about limited evidence and possible androgenic side effects, although usually not seen at those levels. At appropriately low doses, significant masculinization is highly unlikely, but I would never promise that it's impossible. Excessive exposure can cause acne, oily skin, increased facial or body hair, scalp hair loss in some genetically susceptible people, genital tissue growth, or potential voice changes. That's why we start low and monitor. And what about DHEA? DHEA is made mainly by the adrenal glands and acts as a building block that the body can convert into testosterone or estrogen, but that conversation is unpredictable. Oral DHEA does not reliably reproduce the effects of carefully dosed testosterone, and the evidence for improving libido and energy is very limited. It may be reasonable in select situations, but I don't consider it an automatic and definitely not an equivalent substitute. And over the counter products, quality can vary greatly depending on which one, not to mention cost. Before treatment, I usually look at the whole picture: total testosterone, sometimes sex hormone binding globulin, estradiol, medication effects, and other possible causes of the symptoms. Testosterone is then rechecked after starting or changing the dose, along with monitoring for clinical benefit and unwanted androgenic effects. The research specifically involving post-gonadectomy trans women is still small. A recent feasibility study showed that testosterone could be titrated in a female physiologic range without short-term virilization, and it did not establish that every symptomatic person will benefit. Most of our stronger efficacy evidence still comes from testosterone treatment for low sexual desire in postmenopausal cisgender women. So, if something has felt off since surgery, ask your provider to evaluate the whole picture, including testosterone, not just estradiol. You don't need treatment simply because your testosterone is low, but you also should not be told that distressing symptoms are automatically just part of being post op. Have you experienced this after surgery yourself? Did anyone check your testosterone? I'd love to hear it in the comments. Your experience may help someone else advocate for themselves. As always, I appreciate your support, hitting all those buttons. Beep, beep, beep. Um, Please share and let's get the word out. It helps me a great deal, and obviously it leaves a warm and fuzzy feeling in my tummy. We'll talk soon, and let's always remember to love, support, and protect each other. Meow meow.